be covered in this 30-minute lecture. So we just go breeze through a few things which are important from an exam point of view. Embryology is the first part. There's a lot of questions which come from embryology. We just go through how the phase is formed and the mid-phase is formed actually. The first week of gestation is where the palate is formed. And there's all these nasal plateaus, frontonasal process. I think you have to sit with the books, Ferber is better, or any good embryology book. You'll see the processes forming. And what is important is maxillary prominences, which are inferior and lateral to the nasal space. Migrate medially and fuse with the medial nasal prominence to form the primary palate. That's the most important thing. So what prominence, maxillary prominence, and migrate medially and fuse with the medial nasal process to form the primary palate. That is the first one. Now the structures that develop from the primary palate include the nose, the lip, proladium. Proladium is a structure in the bilateral cleft, but it's actually the central part of the lip. And the premaxilla. The premaxilla is the part of the alveolus which involves as the centrals, laterals, and sometimes the lineage. So the normal fusion of the primary palate is complete by the 6th week of gestation. Now, important part of this discussion is the formation of the secondary palate. That starts in the 6th week of gestation. So the maxillary prominences have lateral palatine cells moving medially, and it goes down the tongue. Tongue is quite superiorly placed, and it moves down the tongue. And as the child ages, the tongue moves down, and the palate shifts horizontally. So you can see in this picture. Okay. Yeah, throughout here, we can see that the palate has moved horizontal. The tongue, which was there here, has gone down. And it is fusing in the middle. Now the fusion starts from here, anteriorly to posteriorly. So that's very important because you will never see a cleft palate where there is only a hard palate cleft and a soft palate cleft. That's not embryologically important. You will always see a cleft palate with only the uvula probably, or uvula and the soft palate. And uvula, soft palate and the hard palate up to the incisor foramen. This is possible, different variation. But you will never see a hard palate hole. In that case, it's not a cleft palate. Okay. So eventually they fuse in the midline. Fusion begins in the incisor foramen, proceeds posteriorly towards the uvula. It's like a zip. It just puts down. There's so much of embryonic processes going on during that fusion. Hard palate fuses to the molar of the nasal septum in the 9th week of gestation. So that's very important when you look at unilateral, bilateral, where the molar is positioned. Those things are very important. Full formation about the secondary palate by the 12th week of gestation. So this will give you an idea about the syndromic and the embryology of the eclectic design. If you can access it. Now the questions which may come, this is very important. I just put it together. Looking at so many question papers, I have not seen the latest ones. Sometime maybe somewhere between 4 or 5 years ago I have covered it. So related development of the face and congenital anomalies. Development of cleft palate is straightforward. Development of complete unilateral cleft palate deformity. Now this is important. Then you will have to modify your answer with your knowledge of the development, how it's to the unilateral, how it's to the bilateral. Now in the unilateral, the hard palate, the molar is attached to the non-cleft side. Okay. That's very important. That's one thing which you have to mention when you say left side or right side. The bilateral molar is not attached to any shell. So usually, and 90% of the cases, it's not attached to any shell. So this is the main difference in the unilateral bilateral. The soft palate, everything else is almost the same. Anatomy, we go to the 3 muscles, the levator, the tensor, the palatopharyngeus, and superior constriction is important. So in speech, the levator palatally, what are the functions of the levator? It elevates the velum. Eustachian tube is dilated. In the opening of the eustachian tube, it's the function of the levator. And the tensor has almost no role in the palate. At least what is known is that main function is in the eustachian tube and it comes to dilate the eustachian tube. Now, and the palatopharyngeus antagonistic to the levator tries to pull down the palate and helps it well-built closure. This is kind of a agonistic antagonistic mechanism, so it helps to modulate speech. Now, muscularis uvulae constrictor, again medial displacement of the lateral pharyngeal wall, which helps in the closures of the soft palate. Suppose in some people the palate is a little short, the superior pharyngeal constrictor helps to close. So this is how the palate looks like. Now this structure is in the front here. This white structure, pinkish white structure, is the palatine aponeurosis, and it is it's a fan of fascia that is coming from the chest. So this structure is present in our overall having anatomically normal palate, but in a cleft palate, that structure is only very rudimentary in the corner here. So most of the muscles of the cleft palate, they're pathological and they attach to the heart palate. So this is the main part of the anatomy which we have to reconstruct and make it normal like this when we do surgery. So that's the palatopharyngeus, and then some parts of the levator also goes and attaches to the posterior part of the heart palate. So this is very important, and you have to go through this in detail. Now, again the questions which get down are applied surgical anatomy, anatomy of the soft palate, and soft muscles in the cleft palate. So you have to describe the pathologic anatomy of the soft palate with questions like this come. What are the differences between the normal and the pathological in the soft palate? So this again, epidemiology, this is again a question you can have now. And classification. Now there are so many classifications. One which we use in our department is this one, Callahan and Starks. It's a well established. You will see in all pediatric books and all books. This is a modification by Nabil El-Sahi, which is the two things on the top. These there's the nose and the nasal floor are added on. Otherwise, this is the common Y. This is actually not. It's a stipple Y. It's dot on it. It's a stipple Y. So there is the 2 and the 6 are the lip elements. Alveolus is 3 and 7. Anterior primary palate is 4 and 8. And this is the ipsilateral hard palate. It's 9 and 10, and soft palate is 11. So about that, I cannot ask you which cleft palate have you operated in. You can't tell me with the Callahan's classification. So for that, we have Mohs classification. Very simple classification. Group 1, cleft of the soft palate. Group 2, cleft of the heart of the soft palate up to the incisus palate. Group 3, complete unilateral cleft lip and palate. And group 4, complete bilateral cleft lip and palate. This does not give you the complete picture, but it does not give you the many variations you can see. But for a general purpose, especially if you are dealing with cleft palate, this is the most easiest classification you can verbally use to communicate. Okay. Now, classification of cleft lip and palate again. We'll have to go to the patient presentation. Let's see how the patients come to us. Now, what are the things you will ask in a history if you ever have a patient? Maternal history, neonatal history. Yeah, important because a lot of our patients today come with a neonatal scan. And if they have a neonatal scan and they have been diagnosed, then you know that the patient is kind of ready for the babies when they come out. If they are not, then your counseling should be more intensive. Because usually when they have not been pre-warned, the mother is in kind of shock seeing the baby. So you have to be counseling very strongly. So then you have to do feeding and swallowing. You have to ask about feeding and swallowing. Feeding is obviously present in a cleft palate patient. Other associated syndrome, venous surgery, whether there is a secondary patient coming in. Genetic testing has been done or not previously. So that's and there's a family history. Often I think 20% of the cases there's some known families, developmental history and speech therapy. The baby is are they reaching their milestones in time, and they have any speech therapy, craniofacial, other craniofacial anomalies associated, orofacial development, dentition, and there are any fistulae after this for minor repair. Now we're going to look at the soft palate length, degree of elevation and symmetry during phonation. This is again in secondary cases. Tonsil size and symmetry. Now what you see again, cleft palate with cleft lip. Cleft palate is the most commonly seen in combination with cleft lip. Dentition is affected in this case. Vomer is partially or completely attached to the non-cleft palatine shelf in the unilateral cleft palate. Vomer is usually central in the bile. Cleft at the secondary palate, a cleft at the secondary palate may be variable from an opening in the posterior soft palate, that is the uvula, or just behind the uvula, to a cleft extending to the incisive. There is almost always a separation of the bony shells to the hard palate, which is variable but may extend anteriorly to the incisive. Now, even if you have a soft palate cleft, you might find a small nodule in the posterior corner of the upper. That's what that means. Again, there is another category of patients called soft mucous cleft. The palate has a mucosal continuity, but the underlying levator palatine muscle is discontinuous across the midline and longitudinally oriented, just like any other rough palate. The speech is usually deformed, but not in all cases. So, Callan's classic criteria. They'll ask you it's a question. Soft mucous cleft. What is Callan's criteria? There is the blue line in the center. You can see it in this patient. There is a blue line here. There is a bifid uvula, as you can see, and you can't see that. There is a palpable notch in the posterior artery. What is important in this picture, you can see the muscle here. It is oriented just like in a cleft palate. So essentially it's closed, but it is essentially a cleft palate with often poor speech. So this is a good article. You can see this submucous cleft palate by Brian Softland article. It gives you a classification of submucous cleft. If you're interested. Syndromes and cleft palate with or associated cleft lip has been reported to be associated with the syndromes in as many as 50% of the cases. And with cleft lip and palate together have incidence of syndromes of 30%. So isolated cleft palates have more syndromic associated. Another article review the nasal wall in Western syndrome. In few syndromes you should know. Pierre-Robin sequence is not a syndrome. It's a very important condition because there are around 10 to 20% of the cleft palate patients. It's kind of group of conditions which follow one after the micropnea, glossoptosis, and respiratory distress. Now, 60 to 90% of these patients, not all Pierre-Robin have cleft palates. So 60 to 70% have cleft palate, and that's the article which says so. Now, the main problem is newborns may have severe respiratory distress and feeding difficulty with the posterior displacement of the tongue. And this is a very nice chapter. If you have seen Nelligan's, this is the textbook of plastic surgery. Nelligan's textbook of plastic surgery, I think it's currently in the 4th edition. You can see all the chapters, they are very good. This one is a particularly good chapter which you can understand properly. Okay, so this is in detail, but you can scan through and get the gist out of it. Primary management, keep the baby in prone position. If the baby parents are not comfortable, you put them in a lateral position. Gastric lavage feeding tubes to push the tongue forward, which will help you also feed the baby without the risk of aspiration. Nasal airways, cervical, and the nasopharyngeal airways actually helps you put the air right into the tongue, push it up. And the last one is the tongue limpation is a soft tissue procedure. You bring the tongue forward and suture it to the fuse it to the lip. So that's the first mandibular distractinosis. You know what? Okay, there is something called a velocardial tissue syndrome. It's also called a part of the syndrome that's called the Dyeland syndrome. So very often it is similar, associated with a deletion of the 22q chromosome deletion and detected by patient fluorescent immunohybridization. Characteristic bird-like facial appearance. If you have experience in government and parallel, you see these patients walking in, you know this is the patient. Soft palate dysfunction, developmental delay, and variant cardiac conditions. Okay, there's cyclic hypoplasia also. Poor speech outcomes, even if you repair early and do it, all these problems are there. For us surgeons, what's important is there's something called an aberrant carotid artery. So the carotid artery is medialized. So when we do for secondary speech corrections, there is a flap procedure we take from the pharyngeal wall. So if we are having the carotid in that area, you are likely to encounter serious problems. So that's one thing you have to understand. Okay, these are the questions and roles associated with Pierre-Robin sequence, differences between complete and bilateral cleft palate, isolated cleft palate, airway management in Pierre-Robin sequence, and so on. So this is for feeding, feeding and swallowing, oral pain, failure of clinical. So feeding, baby cannot suck. That main reason is it cannot develop a negative pressure inside the mouth because there is a hole connecting the nose and the mouth. So So that's the problem. And we have special feeders. Urban is the gold standard. Means Johnson feeders, these are the two feeders. And the strategy techniques to allow low resistance to flow, control the flow rate, compress, push the milk into the mouth, baby usually can swallow. Elevated head position during feeding and careful observation of feeding time and the water ingestion. Weight gain and skeletal growth confirm success of feeding. Short term, you see how if you've got baby has got adequate during the day, you look at the urine output. On the long term, you look at the feeding. Okay, sequencing. Okay, I think most of this is done in the time, but I'm not going to go with that. So what are the outcomes you look at when you look at cleft palate? Closure of the cleft palate, of course, that's what constantly separating the oral and nasal cavity. This is something which is standard, so parent expects you to, but what we expect is that we have well-of-pharyngeal sufficiency, the palate will close against the posterior pharyngeal wall when the patient is speaking. That is first and foremost. Absence of compensatory recirculation. That means if it's not closing, then the palate and other structures try to compensate. That should not happen. More importantly, and very, very importantly, is your normal facial growth. So if you are 15 years into your, almost 20, you will really start seeing your own children come back to you. And whatever pretty work you have done is all gone down the drain when you see the children at 15 years, in almost 70% of the cases. So if facial growth is not good, beautiful lip repair will all look unconscious by the time they are 70. So that is very clear and something which we have to do. Most of the problems come from normal facial growth due to cleft palate surgery. Abnormal facial growth due to cleft palate surgery. Occlusion, of course, if there is issues with growth, there will be occlusion problem. Mid-face projection, maxillary arch form, airway pains. So all these are problems which outcomes are to be ideal for all this. When you look at the primary surgery itself, not looking after secondary surgery. So these are the questions, what can come, and you can just go through that. Okay, we'll go through surgery. Now, surgeries, there are so many surgeries. We just brush through all of them. So primarily, we have the first thing you have to know in cleft palate surgery is that we have to try to close a part of the palate during delivery. So that's why we do something called a boomerang flap. Details are not explained here, but this is a boomerang flap. It's from the unilateral side. If it is unilateral, you use unilateral boomerang flap for the major segment, taking pericondrate and move it. Try to close with the nasal side of the nasal mucosa of the lateral segment. So and get the boomerang flap. Most of the pictures from this book, Salia and Paddock, such as benefiting volume 2, classical palate surgery. The very famous surgeon who, one of the people who did the Paddock's technique, which is the most popular technique in classical palate. So that's this book. So the very illustration, and it's easy to understand. So what is the osteo technique of cleft palate repair? It's commonly followed by taking the vomer branch tissue. This is the vomer, this is the non-cleft side. So vomer flap is taken. It is sutured under the mucoperiosteum of the hard palate of the lesser segment, and then it heals like that. So you have a vomer flap close, the entire hard palate is closed during the lip repair. So this is how it looks like after you go for the cleft palate. So then you open and you do whatever procedure you can do a font like a touch procedure, a lateral releasing incisions without submerging, and then you can close the cleft palate. This is one technique. So this is how it looks like. This is actually after a vomer flap repair. You can see that the palate has narrowed down. The anterior palate is just like normal. It doesn't look like this in all cases, but this is how it looks in this particular case. And there's a partial cleft. It's not a partial cleft, it's a complete cleft. The anterior palate is closed in the lip repair. So, and there are many ways. Nowadays we wouldn't be doing this. We have changed our technique of doing cleft palate repair. So this is how we used to do before, and this is what most surgeons do for a cleft palate even now. So I cannot talk about my technique. I should talk about what is general technique and what you are supposed to answer later. So this is true flap palate. This is the currently most popular technique for closing the cleft of hard palate. True flap palate is essentially a hard palate technique. It's to close the hard palate. So what technique is used to close the soft palate? We'll discuss it as we go. The first one is this is the Pintos modification. This is in our list. You'll see this But this is essentially a tube plastic which was devised by Dr. Charles Pinto. I think it's probably independent of Bharat. So this is the same technique, and we use two mucoperiostal flaps, and that's what you see. You erase the incision line, you can see. You put the medial incision, lateral incision, go over to the mucoperiostal, raise the mucoperiostal. As you can see, you undermine the nasal mucoperiostal and oral mucoperiostal. Basically, you leave the bone raw. Nasally and orally, both it is raw. So again, then you pedicle the vessel, greater palatine vessel on both sides. After you pedicle the vessel, you dissect the muscles of the hard palate, soft palate junction. Bring the muscles posteriorly to more an anatomical position. And then you can see you have closed, then you close the nasal layer, if it is not already closed in the lip repair. Then they close the muscle here. In the picture here, you close the muscle from what is attached here. It's brought into a more anatomical position and it is closed. And then we close the soft palate. And then we close the hard palate. Next picture. So this is how it looks. This is the muscle, which is not anatomically aligned. And then we have anatomically aligned muscles here. So this is the soft palate repair. It's called an intervelar veloplasty. This procedure in the soft palate is called an intervelar veloplasty. That is the standard technique. And then you close the hard palate, you put macro stitches. You can take a stitch through the nasal layer to prevent the dead space, and we can take one or two stitches in the hard palate, soft palate junction, and the anterior most. So that's how it goes. That's how it looks. There is a lateral raw area which causes a scar and which prevents a normal growth of the maximum. So that's the problem with this technique. And all techniques, whether it's the flap elevation and lateral raw areas. So you can see the lateral raw area. Alright? So that is the Barrett's procedure. This is the most popular procedure. Now, von Langenbach's von Langenbach's procedure, we have two lateral lacing incisions. As you can see, there is a lateral raw area, but it does not connect, and the whole flap is not taken. This is for complete or partial cleanse of the soft palate and hard palate. Now, bilateral cleft palate repair, you have a central vomer. So the vomer flaps will be taken from both sides, as you can see I'm showing that. And then you take flaps from both sides, and both sides you shoot it into the nasal layer first. So the nasal layer goes to its achieve. And again, the rest of the procedure is more or less the same as in the unilateral cleft, complete unilateral. Now there is many European schools or centers do this technique. They do the lip repair, then they do the soft palate repair, leaving the hard palate open. They believe that if you do that, the hard palate will grow normally, and they do grow normally. These children have excellent growth outcomes, but the speech outcomes are controversial. They are not very sure. They say they are okay, but most people who have done external audits such as the speech outcomes are not up to the standard. So this is one. The second palate, hard palate repair, hard palate will collapse towards each other. So that is done anywhere between. This is not exactly. It was the old one, that 12 to 14 years. Now anywhere between 3 to 9 years. In different centers, different protocols. Okay, so that's how it goes. So later they can close it with minimal lateral releasing incision. Now, we have discussed the hard palate techniques. We have something called the furrow. This is very important because we do furrow in almost all our private palates now. And the reason being, it's got a complete anatomical displacement of the soft palate muscles into a more anatomical position. So there are two Z plastics, one on the oral side, one on the nasal side. 4 flaps. The anteriorly based flaps are mucosal flaps. This is important to understand that in the posteriorly based flaps are myomucosal flaps. They contain both the muscle and the mucosa. So the anteriorly based flap, one on the nasal layer, one on the oral layer. Anteriorly based mucosal flap is on the oral. Again, anteriorly based mucosal flap is on the nasal. They are on the opposite sides. So if you have the left anteriorly based oral flap, on the right you have the nasal anteriorly based mucosal flap. So that's how it's difficult to understand with this half a minute of explaining the furrow. You have to see it to understand it. Okay, and you see 3 or 4, then you will understand. Your brain will register this. So it's a little difficult to do it when you start off your surgical career, but I think it's a very versatile procedure once you know how to manage it. So this is the they introduced it in the Z-plasty. Z-plasty is a procedure where this is the article, Gaynor Furlow, who's started the procedure. And the Z-plasty, any Z-plasty is mobilize tissue from the lateral and increase the longitudinal length. That's what the Z-plasty does. They mobilize tissue from the lateral. Tissue is like this. They mobilize tissue from the lateral and increase the longitudinal length. So the cleft palate length increases and also the lateral decreases. So that means the total peripheral report decreases, whereas the length increases, helping in closure. Okay, this is an old technique, which is what we used to do for soft palate cleft. It's a V to Y incision. There is a V here in the incision, and then here there is a V, and it's sutured in the form of a Y. I think you should know this is a Y. Okay, so this is how. Rest on the soft palate, everything is up to you. What you can do, you can do the intervariate venoplasty or a spasm or whatever. This is a very technology. This is sorry. So this is the weak point procedure. So this is not exactly done in a one. Here just closed it. Although it's a Y, it's actually the same thing put back together. But actually this flap is moved more medially, supposedly to increase the length of the soft palate. So this is the V to Y. We are doing the muscle work. Anyway, that's always standard. And then you can see the V to Y. Now, there's also something called the no flap palatoplasty transformer surgery in England. He had discussed, he had started this procedure and uses a microscope and very radical section of the soft palate muscle center positioning. And there are no lateral incisions in up to 80% of the cases. It's done without lateral incisions. So this is the technique without it. So you can see in such cases, we just want the muscle there. The muscle is here like this. It's moved into this direction. So here is the right of the posterior part of the soft palate. And this is how it goes. This is the diagram. Okay, no flap palatoplasty. So that's the flow. Now what we do now is a furlough with minimal lateral incisions in case of soft palate. So soft palate cleft and clefts of the soft and hard palate. But if it's a completely wide cleft palate, we use what is called Robert Mann bilateral buccal flap. So we use buccal flap to close the palate now. We don't use mucoperiosteal flaps. Reason being, mucoperiosteal flaps pop off of the pouch as the child grows. It looks very easy. Of course, mucoperiosteal flap surgeries are much easier than this one stuff we do. So this is called ACRP, anatomic cleft restoration. This is what Robert Mann has called. So this is the process. You bring buccal flaps to close the tissue deficit in the nasal layer and outer layer. And we bring the buccal flaps from one side into this defect. We do a furlough, and if there is a lag, the tissues don't come together. We put a buccal flap on the nasal side, and then the hard palate is closed with a buccal flap on the outer side. So you can see that in the last picture. So there is a huge defect here, and the buccal flap from the other opposite side comes in.